Reed here. How's it going, guys? Hope everybody's doing well. Today, we're going to have a very interesting discussion. It's about frontotemporal lobe dementia. You know, um, Out of all the dementias, frontotemporal lobe dementias is one of the most challenging to diagnose and to assess and to come up with a treatment plan because you have multiple points of failure. Whereas in things like Alzheimer's, it's just in the hippocampus, right? It's just memory, nothing else, at least in the early stages. And remember, in Parkinson's, it's in the basal ganglia. So it's mainly about movements and things like that. So those damages, although they seem to affect the whole symptom, seem to be somewhat more localized. But with frontotemporal lobe dementia, it's progressive damage throughout multiple areas, particularly when it starts off in the deeper brain structures, starts to move forward and anteriorly and upwardly to more of the prefrontal cortex and the frontal lobe structures, where it began to interfere with your perception of reality, your temperament, and also your ability to sort of understand and process things in your environment. It can impair your ability to make decisions, right? So just look at this name, frontotemporal lobe dementia. So I'm just going to take you through this step by step, and hopefully it'll be useful for you. And please feel free to like, share, subscribe, right? And let's get into it. Good. Okay, here. Let me see, explain. Explain frontotemporal lobe dementia. Okay. Frontotemporal lobe dementia, or FTD, is a progressive brain disorder. Remember I said progressive? It starts at one area. They can have damage to multiple areas, or it can continue to progress. And this thing evolves over time. It's very complicated. A progressive brain disorder where nerve cells in the frontal and temporal lobes gradually deteriorate, leading to changes in personality, behavior, and language. I went through the prefrontal cortex, and the purpose of that prefrontal cortex is sort of connect all of these things, and the process of matching and filtering and connecting and pairing all these things, you come up with what's called abstract reasoning. And with that abstract reasoning, it allows you to get a more sophisticated interpretation of the world. You see more than just the things around you. Instead of seeing just the objects of the things around you, you are able to put all the objects together, and those 10 objects make one object. The fact that you can look around and see 10 different concrete pieces and put them together and say, this makes one piece. That's abstract reasoning. That's what the prefrontal cortex over here near the temporal lobe can help you with. So if you have damages to that area, you have damages in your perception of reality, right? Now, let's look at the frontal lobe. Let me show you some of these things I'm talking about. Okay, so here's the temporal area, right? Over here where this prefrontal cortex should be around here, right? It's this area that doesn't, if you probe it, it doesn't result in any type of muscle movement. So this frontal, that's the frontal. This is the executive component, executive function part of it, attention, concentration. And here's the temporal lobe here. Over here, where this prefrontal cortex is, where you have your abstract reasoning, so failures and ability to interpret things in the environment. And of course, the temporal lobe. Remember that amygdala is deeply connected to this temporal lobe and their structures. And it's in temporal lobe that feeds that amygdala, and it can trigger And this is where things get. This is the location where the trigger happens. This is the switch. It's the switch for the trigger right here, the temporal lobe. So frontal temporal lobe dementia. Um, that makes sense. Okay, let's see here. Okay, I think I can go back here. Okay, yeah. So it's a progressive brain disorder where nerves in the frontal and temporal lobes are gradually deteriorating, leading to changes in personality because it affects the frontal lobe. The frontal lobe is attention, concentration, planning, organization, things like that, right? Also, behavior. Remember, you need to activate that frontal lobe in order to shut down all of this unnecessary behavior and be still, right? So behaviors, unpredictable behavior, impulsive behaviors, inability to sort of restrain your impulses, and language, because remember, Broca's area is over there in the temporal lobe too. So then damage to the temporal lobe can cause problems in that Broca's area. Symptoms include impulsive loss, impulsiveness, remember, frontal lobe failure, loss of inhibition, frontal lobe failure, apathy. That's in the deeper brain structures, such as around the basal ganglia. Apathy can also be considered a separate disorder in and of itself. We'll get to that when I review apathy. Empathy, right? Changes in eating habits, things like difficulty speaking and writing. Remember the language. Frontotemporal lobe dementia typically affects people between the ages of 45 and 65. 45 and 65. It's relatively young, right? Okay, causes. The primary cause of FTD is still unknown, but it is characterized by abnormal build-up proteins like tau. Look, there it is again. There it is again. Right. That's remember. That's something that's common in many of these dementias. The buildup of that intracellular debris, and I think I read one source that says that the debris field can get so large that it could displace the nucleus. I never could perceive of those tau particles getting protein particles getting that loud that it takes up that much landscape inside of a molecular factory. And apparently, the way you reduce this size is through fasting. The size of the trash pile is through fasting. Um, a significant portion of cases, okay, yeah, characterized by abnormal buildup of proteins like tau and TDP 43. This is the first time I've heard of it in the brain's frontal and temporal lobes, right? A significant portion of cases, 40%, have a genetic basis involving mutations in these genes. Head trauma and thyroid disease also linked to the disease. Now, whenever I see these patients, I always think of genetic etiology because the persistence of it. If the behavior was secondary to intoxication, it comes and goes with intoxication. If it's present with any type of illness, it should come and go with any type of illness. However, this seems to be stable over time, and when you start to seeing it at age 45 and people in their mid 40s, it's very difficult to. I think of this as a diagnosis because you start thinking of things like schizophrenia. You start thinking of things about the cognitive impairments in schizophrenia, right? So in schizophrenia, most of the patients over time can develop cognitive deficits. And so when they start to develop the cognitive deficits, you have the perceptual disturbances and then you have the behavioral disturbances. Or is this a case also in the area I work, we have a high proportion of patients diagnosed with schizoaffective disorder, right? Is it frontotemporal lobe dementia? It's very interesting to see. So I can see, at this age of 45 and 65, I can see it's be very difficult to tease out the diagnosis and separate this from someone with schizoaffective disorder. Symptom types. Um, FTD is a spectrum of disorders with two main types affecting different functions. Yeah, it's a spectrum of disorders. I mean, you have to get prepared for this. Um, okay, the behavioral um, issues connected with it because you have the frontal lobe impairment and the impulse control and things like that. You know, primary progressive aphasia, okay, primarily impacts language ability due to damage in the temporal lobes, right? So the communication issues, right? So look at this. Imagine a 45-year-old patient with an aphasia, speaking difficulties and things like that, difficulty forming words and grammatical errors, struggling to find the right word. Okay, now remember, sometimes in patients with schizophrenia, they present with more of a disorganized thought process, right? Or they can present with a form of thought halting or thought blocking. How do you separate this stuff from this? For men, a primary progressive aphasia, all right? But still, dysfunction in that temporal lobe. Remember the language centers. So the frontal areas for behavioral issues, executive functioning issues. The temporal for areas for communications, agitation, and things like that. Let's see here. Progression and impact. FTD is a progressive condition, meaning its symptoms worsen over time. Yeah. As the disease advances, the person may experience increased physical problems such as difficulty swallowing, loss of bowel control, or may eventually need significant care. Yeah, it's important to really help the families understand exactly what you're dealing with here, and because it becomes very complex, and these patients require very detailed evaluations and very close follow-up to make sure they're stable. Um, and you want to sort of prepare the families and the patients sort of understand the progression of this, right? Um, in Alzheimer's, you have the localized damage of the acetylcholine networks, primarily in the hippocampus, right? And so in early Alzheimer's, the issue is only memory. They have preserved executive functioning and preserved reasoning and behavior and reasoning skills and preserve regulation of their moods and behaviors. Okay, and that's in the early stages. So you don't really see the cognitive problems in early Alzheimer's. If you look at Parkinson's dementia, which is primarily damage to the dopaminergic neurons within the substantia nigra of the basal ganglia, is still located to primarily movement. So in the early stages of the Parkinson's dementia, you'll have movement and motor dysfunction. You shouldn't have as much of the cognitive dysfunction, like the language problems, the executive functioning, the problems like things like that. You may have like mass facies and stiffness and things like that, because that cranial nerve is connected directly to that basal ganglia. So those facial expressions are a very good idea of what's happening to how the basal ganglia is functioning. But in that early stages of this Parkinson's dementia, it only affects the motor function, not the cognitive function. And that's one of the differences. And remember, Huntington's disease, the choreiform movements and things like that. But remember, the difference between the frontotemporal lobe dementia is all of the behaviors and the cognitive stuff. So you see that first. The behaviors, disruption, agitation, combativeness, aggressiveness, restlessness, and things like that. The hyperglutaminergic state, right? So remember, in frontotemporal lobe dementia, the frontal lobe is damaged. They don't have the brakes. So imagine a hyperglutaminergic state. Glutamine is the neurotransmitter present throughout all the tissues, and it's excitatory. Hyperglutaminergic state in a person with no brakes, right? So you can see the stories of the disinhibited agitation, combativeness, or aggressiveness. I mean, in your face, don't you do that again? You don't even know what to tell. Don't do that again. But still, this affect that's pointed outward, you're sort of noticing that. And again, the language and communication problems would be very prominent. So one of the ways to distinguish between these, if it's just like memory, think of just Alzheimer's. If it's movement, think of Parkinson's. If it's choreiform, think of Huntington's. If it's agitation, combative aggressiveness, or cognitive problems, think frontotemporal lobe dementia. you know Let me see if I have any questions. Let me know if you have any questions so far. Let me see here. Okay, I have Moeen here. Hey, Moeen, how's it going? Appreciate your question. All right. How does FTD affect family dynamics and caregiving? Complicated. Um, I take a lot of effort to help the patient, and I can use this video too to help the patients understand the importance of understanding how this disorder is going to progress. It's a stair step phenomenon. I lost my train of thoughts, but all the other diseases, there's a slow, gradual decline, right? There's a gradual progression over time. And so the family's history would be like, yeah, she started forgetting her keys, then she started forgetting her purse, and then she started leaving out the house, and then she started disappearing, things like that. Whereas in frontotemporal lobe dementia, because the mechanism of injury is different, they present like the patient all of a sudden left the house and started fighting with the neighbor, and the neighbor had to call the police. And then the patient ran and gave the police chase. They had to bring her back to the emergency department, and now she's arguing with the staff, right? That's how frontotemporal lobe dementia present with the affect and cognitive changes. And so this happens in what's called a stair step phenomenon. So all the other ones occur more gradually, but this in more of a stair step phenomenon. So all of a sudden they changed. All of a sudden this happened. And unfortunately, they may not recover to their previous level of functioning. So you have to prepare the families. Hey, this when you take your loved one home, that we're going to have to anticipate that there's going to be another one of these episodes. And when they do have another one of these episodes, it's highly likely that they won't get back to where we were while we're having this conversation now. So I do a lot of testing, like the brief psychotic rating scale. That should give me some idea of any type of psychoticism or psychotic process. And that brief psychotic rating scale allowed me to sort of monitor the activities in that mesocortical pathway and that mesolimbic pathway too. The higher the scores on those BPRS symptoms are associated with positive symptoms, and those are associated with hyperactivity in the mesocortical pathway. So I also use the confusion assessment method to look for any type of delirium, and that helps track, their mental status at the time. And also things like the Young Mania rating scale to look for any signs, to track any signs of mania. So I at least track those parameters as they go through this process, so I can see if there are other things influencing the patient's disease process. And hopefully, if I can pick things up by changes or abnormal changes in the scales, then we can sort of refocus on those networks and sort of use the changes in those scales as a way to sort of focus on how we're going to modify our medications and focus on it. So I think that's all I have. I'm at the 19 minutes point at this far. Oh, let me do this. Let me see. Explain the medication treatment for frontotemporal lobe dementia. So for the most part, I look at the stuff, and what you are treating, if it's agitation, you're going to have to stabilize things. It's a glutamate issue. If it's rage or combativeness, then you want to use, for the temporal lobe, you want to use those mood stabilizers. And and it's very effective. So just like temporal lobe epilepsy or something like that, we can still control those with mood stabilizers. I typically use, on a regular basis, for the agitation aggressiveness, I typically use both Depakote and lithium. One of the reasons why Depakote is very effective is because it results in an increased threshold for action potentials, and therefore it has more of an inhibitory tone on those networks in that the temporal lobe, and so it can decrease overall activity in that network. And so hopefully the temporal lobe won't be as aggressive, won't be as active, and hopefully it won't the um, dominate how the ego presents your reality. You know, with too much contribution to your temporal lobe, you start to feel the rage and the anxiety and restlessness and combativeness, and it tends to be surrounded by you because it's created through your ego creates the environment through you, and all those things make up all the objects in your environment. So it's a very interesting process. Um, so for those, we want to use things like Depakote, right, and lithium. You know, these Depakote and lithium also causes down regulation of glutamate receptors and upregulation of GABA receptors. The GABA receptors are inhibitory. So if we want to start treating this agitation and combativeness from the frontotemporal lobe dementia, we can definitely go with Depakote and lithium. Lithium also has an effect on sort of stabilizing the frontal lobe, and it's also associated with decreased impulsivity, right? It's also associated with decreased risk and attempts for suicide. So it has a lot of these beneficial effects. And so both Depakote and lithium are normal stables of medications when I see these patients. I need to stabilize and lock in that mood. Um, so if they're having any depression, of course, you're going to have to go to your SSRIs. Your SSRIs, depression or anxiety is an SSRI issue, you know. And if we start having the psychotic symptoms, of course, you're going to have to go to the antipsychotic medications if you start picking those up. So um, there's no there's no straightforward treatment. You just have to understand the mechanics of a human body and sort of start putting things, piecemealing things together. So let me just go through this real quick and see what they say here. There is no cure or treatment to slow FTD, but medications can help manage the symptoms, primarily behavioral issues. That's why I went with the dual mood stabilizers, both Depakote and lithium. I'll give them both loading doses. Depakote extended release and lithium extended release in the morning. So hopefully we can try and get them to a therapeutic dose as soon as possible, start stabilizing some of this agitation, right? Okay, some of the behavior, and see the SSRIs, because it can be an issue connected to depression or anxiety. Okay, yeah, commonly used for depression, anxiety, apathy. I would still go with the mood stabilizers for apathy because I think it's a more complicated issue than just serotonin. Um, and compulsive behaviors, while trazodone can help with agitation and sleep problems, I would say trazodone can help with sleep issues, but not the agitation. Okay, right. Antipsychotic medications are reserved for severe aggression or psychosis and is used with cautious and serious side effects for people with dementias. Yeah, because the side effects, you know, and then you don't want to be placing patients with dementia on antipsychotics if they really don't need to be one. And this is a dementia, not a this is a dementia, not a psychotic disorder. So antipsychotic medications are not absolutely necessary. Right. For motor difficulties, okay, you can use other things. All right. Okay. SSRIs, yep, trazodone, antipsychotics. Okay. All right. Um, I think that's it for now. I think that's it. Okay. So we're at 23 minutes. I think I'll go ahead and end for now. And it's a pleasure. If you have, please, you can write them in the comment section. Like, subscribe, and share. Weed out. It's been a pleasure. Take care, guys. Ciao.